So our next speaker is Dr. David Kooby. Dr. Kooby trained at Stony Brook, then went up to Sloan Kettering to do a research fellowship, then finished up his training at Vanderbilt and came back to Sloan Kettering to do his surgical oncology fellowship. As you heard this morning, David is right on point, dissects things out pretty much like a scalpel. And one of the things that I can say about David is that he was one of the first people in the country that began to methodically attack laparoscopic and minimally invasive resections of tumors other than liver. And so the challenge that he undertook a decade ago was to basically prove that doing these things by minimally invasive approaches was equivalent to doing them open. So I think if there's one thing I know David for, it's for that, and today he's going to talk to us about cholangiocarcinoma. David, welcome.
Thank you for that nice introduction. Thank you, Dr. Katz, Dr. Espat, Dr. Soma, for inviting me back. I am always stricken when I walk into this hotel and I get some heartburn and I remember, oh yeah, I took my oral boards in surgery in this hotel. But Dr. Brennan, I passed. I bait and switched you a little bit today. I decided to stay above the cystic duct and talk about hilar cholangiocarcinoma and intrahepatic cholangiocarcinoma. So you'll have to invite me back to talk about gallbladder cancer another day. This is where I come from. This is the Winship Cancer Institute in Atlanta, Georgia. Here's a little schematic map. That's my home, the little star. That's where Emory is. That is the Clifton Corridor that also houses the Center for Disease Control, 3-mile drive. We have other sites in Midtown, Grady Hospital, and that is the Atlanta VA. More recently, we've expanded our boundaries. The red box is what I showed you before. This is currently now also, I'm director of a new location 7 miles up the road. So now this is the Kooby Triangle. Atlanta's special. It has the Georgia Aquarium, largest aquarium in the world by 4 cubic meters. We have the CNN studio, which you should visit, and the High Museum of Art, as well as some other things such as the World of Coke. And we have Sanjay Gupta, the CNN correspondent / neurosurgeon. So what we'll talk about today in the next few minutes is to understand some of the surgical biliary anatomy. This is tough stuff. This is stuff that a lot of medical doctors do not get, and our trainees come in and have to learn it, and sometimes some of the higher-ups don't even get it. So we'll talk about the anatomy and how it pertains to cholangiocarcinoma and sort of what is cholangiocarcinoma. Primarily talk about surgical therapy. I'll discuss some about hilar cholangiocarcinoma and then intrahepatic cholangiocarcinoma. Review our outcomes, and just touch upon some of the other therapies. Here's the bottom line. So earlier this week at the American Surgical, I tried to convince people that for pancreatic cancer, margins do not matter. For this disease, maybe they do. Complete resection with negative histologic margins is the most effective treatment modality. That's the punchline. Cholangiocarcinoma, relatively uncommon malignancy, endemic in South America and Central and Eastern Europe. It is less common than gallbladder cancer, and the incidence about 1.5 per 100,000 people. A little higher propensity to show up in men than in women. This is a cancer of older people. What are the risk factors? Primary sclerosing cholangitis, autoimmune process that causes the bile ducts to become ill. Bile stasis happens, bile doesn't flow, sets up this chronic inflammatory state that begets malignancy. Stone disease also can be a chronic inflammatory process. Parasites such as Clonorchis and Opisthochus. Radionuclides like Thorotrast. It was a great contrast agent in the 1930s and 40s. Unfortunately, it emitted alpha particles which caused cancers, specifically biliary cancers. Congenital cyst disease and abnormal biliary pancreatic duct junction. Over here you'll see a bile duct coming down to the ampulla vater. Here's the pancreatic duct. There should be a short common channel right here. And a long common channel is one of the anatomic differences whereby pancreatic juice can reflux up into the biliary tract, thereby causing that inflammatory state, giving rise to these cancers. Molecular basis of cholangiocarcinoma, not entirely worked out, but there are emerging data. I won't go into those today. Here is an example of primary sclerosing cholangitis. These are normal bile ducts. These are abnormal beaded chain of lake type ducts, and that's what you see with this autoimmune process. This is congenital biliary cyst. Here it's shown in an MRI and a coronal view. You see this cystic structure right here. If this showed up in an 80-year-old, we'd leave it alone. Shows up in a 30-year-old, well, there's a lot of time for that to become a problem, and that merits surgical resection or consideration. This is a nice schematic of the liver developed by one of our research fellows. Overlie the vena cava, the portal vein, the hepatic artery system, and then the biliary tract. So there is a lot going on in the liver. Take away all of those, just concentrate on the biliary tract. We have the gallbladder with the cystic duct. Above the cystic duct is what we're going to be talking about today. Common bile duct here, common hepatic duct, right and left hepatic duct. So if you have a tumor that's within the liver that gives rise within the intrahepatic biliary tree, that is intrahepatic or peripheral cholangiocarcinoma. If you have the malignancy develop at the hilum, these are known as the Klatskin tumors. This is what a gallbladder cancer is, and this is a distal cholangiocarcinoma. They're all the same cell type, but the difference is on how they're treated. So if we're above this red line here, we'll call this the Maginot line or whatever you want to call it. The liver resections are going to be key for the tumors that show up within the liver. In the bile duct in the centrum, the hilum, the Klatskin tumors, those are going to require both a liver resection as well as a bile duct resection and reconstruction. Those are pretty much the hardest operations we do in general surgery. So, intrahepatic cholangiocarcinoma, not that common. It's a small percentage of cholangiocarcinomas. These will show up on the imaging with rim enhancement and delayed contrast filling. So, not very bright like a hepatocellular carcinoma, but they enhance on the later phase. These patients typically are not jaundiced, but they can be. The ones that present down at the hilum, the Klatskin tumors, these will usually present with jaundice because they present more as a stricture or narrowing of the flow of bile. These are very difficult to treat. And then this is distal cholangiocarcinoma that will usually be treated with a pancreatic duodenectomy or Whipple procedure. So what do these tumors look like and what do? They frequently have submucosal tumor extension. They extend beyond the actual mass itself, 5 to 20 millimeters in general. They can be unilateral or they can be bilateral, which present as real surgical problems. And typically, as I mentioned, liver resection in combination with the bile duct resection is necessary. Dr. Klatskin, a pathologist, described this entity in 1965. How do we classify these hilar tumors? Well, there's the bismuth classification, which is the most common of all that are out there. This is the hepatic hilum, so right bile duct, left bile duct. This is the confluence, or where the bile ducts come together to travel down to the common bile duct. If a tumor approaches the hilum, it's a type 1. If a tumor involves the hilum, it's a type 2. If it extends up one side, the right, it's a type 3A, up the left side, it's a 3B, and a type 4, which are not technically surgically resectable, might be a consideration for transplant. We'll touch upon that a little later. MRI is a wonderful modality for defining these tumors and planning surgical strategy. Here's a normal MRI showing left and the right hepatic ducts and the common hepatic duct right here. This is an MR showing a type 3A cholangiocarcinoma. You lose the common hepatic duct and the flow to the right side of the bile duct. How do we decide whether these can come out surgically? Well, you want to determine if you can completely remove them. You don't want to remove part or most of them. You want to remove all of them. So can it be done with enough liver remaining, adequate arterial and venous supply, and good biliary drainage? You have to determine what the extent of the disease is, like any cancer, what vessels might be involved, and whether there's evidence of hepatic lobar atrophy. So this is the right side of this patient's liver. This is the left side. Typically, the right side of the liver is about 60% of the volume, but in this case, because of the cancer at that biliary confluence, it's caused drainage problems to the right side of the liver, which over time have caused that side to atrophy, and you get a compensatory hypertrophy of the other side. That will impact your decision to operate. There is a nice study from Bill Jarnigan, a good description of how he decides that these come out. Bottom line is, I'll simplify this to say that as long as you can preserve biliary drainage and venous and arterial supply to one side of the liver, then you can consider resecting these. Some of the tests we use to work these out and make these decisions, well, there's basic laboratory studies and the CA19-9, which I'll mention in a moment. CT scan versus MRI depends on the strength of your institution and what you're comfortable with. I think in general, if you have good quality MRI, it does a little more for this disease. Cholangiography, I'll mention in a moment as well, and then some controversial methodologies such as whether we should actually drain these patients. They have biliary obstruction, whether we should put stents in them before or not, or just operate right away, where PET scan falls in, and then staging laparoscopy. So I mentioned MR, very useful. I think it's the way to go, and if we can get MRI before we do the biliary drainage procedures, it's even more helpful because some of the subtleties get lost once a biliary drain is in place. ERCP, this is the technique whereby an endoscopist will put the scope down the mouth into the stomach, cannulate the bile duct, and then inject contrast to help define the bile duct. You can also do brushings and biopsies and place stents, so it can be diagnostic, define anatomy for surgery, but also therapeutic. PTC, same technique, except it comes from the abdominal wall. So the catheter goes through the abdominal wall, down through the liver, into the intestines. And just like that, you can drain the patient, but also get biopsies. And then MRI, as I mentioned. So when they do the ERCP or the PTC, they will oftentimes insert something like a pipe cleaner, a brush, and they'll take some cells and they'll see whether there's cancer. And patients come to us and say, how can you even consider doing a big operation on me when you haven't proven that there's cancer? Well, the sensitivity of brushings for bile duct cancers can be reported as high as 100%, but also as low as 20%. It's probably somewhere in the middle, in the 50-40% range. So a lot of times we're doing big surgery without a histologic diagnosis. Spyglass, just to mention a technique, it's pretty neat. It's a mother-daughter scope. You put the scope in. It has a smaller scope, fiber optics, that goes within the scope, and you can go up into the bile duct and actually take a look. It's a wonderful technique for visualization, allows for biopsies, and targeted mucosal assessment. It's expensive. Here's just a summary of costs. It's $60,000 a pop, 20 uses, and then you have to revise some of the equipment that's on that list. The point of all this is that technology's out there. You have to figure out if it's beneficial. You need to do the studies. To stent or not to stent? Well, if the patient has cholangitis and is sick, then they need to be stented. They have an infection in their bile. That has to be drained. It's just like an abscess. Obstructive jaundice with liver and renal dysfunction, that would also need to be drained, and you wouldn't consider operating on these patients until they've recovered, and some of these patients never will. There's also the controversy and discussion about if you don't drain the patient and you operate on them, well, if their liver's not healthy enough, it's not going to recover after you remove part of it. So that might be an indication for doing it. And then obviously if the patient's horribly symptomatic, they can get horrible pruritus. So by draining them, we're attempting to lower the serum bilirubin to improve liver function, but by stenting them, we may be increasing infectious complications. So one paper from one of the Memorial trainees showed that in 67 patients that underwent resection, there was no liver failure postoperatively in patients who had at least 30% of a liver volume remnant behind after surgery. So they advocated against routine drainage of these patients. What about PET scan? One point I want to make here, these tumors can be nodular, form a mass. They can be infiltrative, that grow in sheets. And those tumors that grow in sheets will not be picked up reliably by PET scan. So this is not a mainstay of assessment. Laparoscopic staging, that's putting the telescope and looking inside before you make a big cut. We can pick up small tumors that are sometimes not seen on imaging. There's a little area in the peritoneum as well. So how does laparoscopic staging work? Well, Sharon Weber, also a Memorial trainee from the past, who's in Wisconsin now, 100 patients with potentially resectable biliary cancers, of which 56 had hilar cholangiocarcinoma, and she showed a 25% yield for those patients that had hilar cholangiocarcinoma in changing the management based on the 15-minute maneuver of putting a telescope in the belly before making a big incision, sparing a lot of patients big incisions who were not going to benefit from surgery. Big summary slide. The more numbers on a slide, the less I have to say about it. But bottom line is we're looking at all these studies, increasing number of these studies, increasing percentage of liver resection as a component of the therapy for hilar cholangiocarcinoma, not just resecting the bile duct, showed an increasing number of complete margin negative resections and improved survival. So how does it look? Well, this is the base of the liver with the bile duct. There's the tumor, gallbladder's being pulled down. We're going to make a transection to remove the bile duct as well as all of the liver that's to the right here. And then what we're left with is the left side of the liver with the bile duct that we reconstruct, and this is what it looks like in the patient. And I'm sure Dr. Geller is having a heart attack because this is with a big incision instead of laparoscopically. Technique for reanastomosis, here's the bile duct. This is a Bloomgart-Kelly technique, near and dear to all the folks who trained at Memorial. Dr. Bloomgart popularized this technique a while ago, showing that you sew the back wall of the bile duct after you've sewn some stitches in the anterior wall to lift it up and get better exposure, more reliable anastomosis. Oftentimes we'll do a node dissection to dissect out the artery and the vein and send off the nodes. Realistically, about 50% of patients who undergo this surgery get nodes harvested, but it's very useful information. And then this is the root on Y reconstruction that many of you may have wrestled with the anatomy and understanding it, but what we do is we disconnect the bowel over here, bring it up to the bile duct to sew it in place. What we do not want is for GI contents or enteric contents to travel back up into the bile duct and cause cholangitis. So we reconnect the intestines downstream for food to come this way and bile to come this way and meet down below. Treatment summary, complete resection is the only effective therapy. Outcomes after an R0 or a complete resection, 5-year survival is still kind of poor, 25 to 40%. Few patients that present are actually resectable at the time that they present, and it's not uncommon that at the end of the day the pathologist will say, hey, you left some cancer behind. Oftentimes just fixing the bile obstruction is the key to this patient's therapy. Maybe they can get on some palliative chemotherapy, and we do have some information there. How much time do I have left?
6 minutes.
Okay. I'm going to go through just a couple more points then. Orthotopic liver transplantation. So this is not just removing part of the liver with the tumor, but it's actually removing the entire liver and trying to see if you get a benefit from that. The initial experiences with this were not good, but more recently it's been done systematically by the Mayo Group, which what they did was first attained a diagnosis. They did this either with the brushings that I mentioned earlier, with fluorescence in situ hybridization techniques that look for abnormal cells, with elevated CA19-9 and the malignant stricture. So that chemical test, the CA19-9 being elevated and seeing the appearance of a malignant stricture on MRI was enough to get some of the patients on the protocol. They gave intensive preoperative chemotherapy and they gave brachytherapy, radiation. They kept the patients on Xeloda up until the times of the resection. They did a staging laparoscopy to make sure there was no obvious metastatic disease, and then they resected them with a transplant and gave them a fresh liver. Well, 5-year survival, 73%. I showed you 25 to 40%. This is considerably better. Very highly selected group of patients. The first rule in the protocol was that they were not candidates for straightforward resection. I think what I'll do, better off to stop now and just take questions?
Yeah, I think it'd be a good idea.
Let's do that.